Welcome to It's All in Your Head, presented by Swingle and Associates in Vancouver. If you're a mom, we salute you today with a subject that has led to many different opinions, discussions, and treatment options. We're talking about attention deficit and hyperactivity learning disorders. The star of our show heads up a clinic that offers completely natural, drug-free treatment for these kinds of issues. For 7 years, he lectured at a little school you may have heard of called Harvard. Prior to that, he chaired the Faculty of Child Psychology at the University of Ottawa and was clinical supervisor there for 10 years, ending in 1997. Since then, he's been here in Vancouver and is one of the leaders in biofeedback and neurotherapy, a safe, medically certified treatment to a wide range of conditions that originate in your head. Good morning, Dr. Paul Swingle.
Good morning.
Today, we are going to talk about what biofeedback and neurotherapy is and how it works. Why taking drugs like Ritalin is the worst thing your child can do, the differences between ADD, ADHD, and other learning disorders, and why that learning disability may not be a learning disability at all, but instead a trauma that has your child completely distracted, possibly depressed, and it could even be a head injury. We'll also be taking your calls with regards to these types of learning challenges or any other brain-related conditions. Well, let's start with what you do on a daily basis. And, this is something that brings a lot of people to your clinic, ADD, ADHD. And we'll start with the diagnosis, and you say that it's one of those very commonly misdiagnosed conditions.
Yes, this is a wonderful topic for Mother's Day. The first thing I'd like to say to mothers is, remember, you outrank everybody. It's your child. You make the rules. Don't allow yourself to be pressured into anything. A lot of mothers don't really appreciate that fact, and they get pushed all over the place by teachers who want their children sedated, by physicians who want to do this, that, and the other thing, and even neurotherapists. So I just want to emphasize on Mother's Day, mothers, you outrank everybody. Okay, having said that, ADD and ADHD are wastebasket diagnoses. Any child who's having any difficulty is very likely to be dumped into that basket and sedated. We have an appalling record in terms of how we treat our children. We have communities in this area in which 50% of the male children between 8 and 12 years of age are on a psychotropic medication. That's an outrage. The frequency of something like ADD should be about 3% in the population. So if we looked at how many kids should be on some sort of medication for this sort of problem, it should be in the range of 3% or so. Now, there are many, many forms of ADD. If you look at the psychiatric manual, they only talk about 3 types: inattentive, hyperactive, and combined. When you do the brainwave assessment and look at the neurology of it, there are at least a dozen subtypes of conditions that will give rise to problems of sustained focus in children. The traditional classic form of ADD, which I refer to as common ADD, I've done a few papers on these things. What that is an excessive amount of slow frequency activity in the brain, and these slow frequencies are associated with sleep, daydreaming, mind wandering, and if you're putting out too much of that, then the child has a tendency to drift. And there are some really frustrating forms of this in which when you challenge the child, it gets worse. The brain might actually look okay at rest, but you get the child to read or count backwards, whatever, and this excessive slow frequency emerges. And as I said, the harder he tries, the worse it gets. Enormously frustrating. If there's too much of the slow activity, the brain is really hypoactive, and it's painful for the child to sit still. It's hard for us to really understand that concept, but it's painful for them to sit still. So what do? They bounce around. And the bouncing around is self-medicating behavior. They are self-stimming. So that's the hyperactivity component of it. Now, you can medicate these things, and the evidence is compelling. After 3 years, the assessment of a medicated and a non-medicated child, there's no difference between medication and placebo. As a lead-in, can I read a little note from a pediatrician?
Absolutely.
Is this a good time to do that?
Perfect.
All I have to do is find it, right?
I'm sorry, I was drifting off there. I wasn't paying attention.
Okay, the title of this is Whose Prescription Is It Anyway? And it's Dr. Howard Markel from the University of Michigan Medical School. And he talks about the mother walks in with the child. The day we met, she had already decided what she wanted to do. I was being told to write a prescription for Ritalin. Now, we're going to get into the direct drug company to patient advertising that we see and the devastating effect that's having on our culture. That's a reflection of that. And this is a quote from the pediatrician now. Quote, many teachers and parents of kids with ADD prefer their charges to be medicated, and many children resist these attempts. Here is my dilemma, writes the pediatrician. The boy's mother, and not the boy, wanted the prescription. The law defines a 14-year-old as a minor, but given that his condition was hardly fatal and essentially a behavioral issue, to whom should I have listened? The mother or the child? The mother wants a more controllable child. The boy simply wants to be what he perceives his true self to be. He continues, each month I see the boy to remove his prescription for Ritalin and to make sure that there are no serious side effects. There are serious side effects of these things, which we'll get into. At each visit, he greets me with a deep-rooted but quiet anger. His fidgeting and outbursts seem to have diminished, but there has been little improvement in his schoolwork. Last year, he barely passed the 8th grade, and his mother admitted that 2 of his teachers simply elected to pass him to avoid a repeat year with him. Quote, nevertheless, the mother is delighted with the results. So what is the medication doing here? It has nothing at all to do with the kid's achievement. Schoolwork hasn't improved. The teachers are passing him to get rid of him, but he's sedated. Now, the beauty of neurotherapy and other kinds of treatments that address brain activity is they change the problem where it resides, and that's a neurological issue. When you correct that, the symptom abates, the developmental process kicks in and does our work for us, and once it's fixed, it's fixed. You medicate it, 3 years later, you're going to have the same problem. And in adulthood, you can have a continuation of these problems unless you continue to medicate them. And we'll go into some adult implications of the ADD a little later in the broadcast.
Well, let's talk exactly about what neurotherapy does and what biofeedback is when we continue. Dr. Paul Swingle is here from Swingle and Associates, a clinic on Melville Street in Vancouver. His telephone number there is 604-608-0444, and being that it's Mother's Day, we're talking about ADD and ADHD. And let's get into neurotherapy and biofeedback. If you're new to this program, you may have heard the term before, but you're not familiar with exactly what it is and what it does. Let's talk about what it is you do, Dr. Swingle, that you've done so well for so long.
It's really very simple. What we look at is the functioning of the brain. Now, a lot of folks are familiar with scans and MRIs and that sort of thing. What they do is they look at the structure of the brain. What we look at is the functioning of the brain, the electroencephalograph, the EEG. Most listeners are familiar with the EEG. If somebody they know has a seizure disorder, they're very likely to have had a hospital EEG. We're now able to do full head maps as a simple in-office procedure. We can actually look at subcortical structures within the brain with simple in-office electroencephalographic assessments. What we look for are areas of inefficiency in the way the brain's processing information. That permits me to tell a person why they've come to see me. We don't ask a person why they come. We do an assessment and tell them why they're there. The same is true with ADD. There are many, many, many different forms of neurological conditions that give rise to attention problems in kids. Now, once we isolate an area of inefficiency, the way it's corrected is referred to as neurotherapy. The backbone of neurotherapy is electroencephalographic biofeedback, brainwave biofeedback. What we do is we set it up so that when the brain is doing what we want it to do, the child hears a tone, sees something move on the screen. Now, we make that as a form of a video game that they play with their brain. So when the brain's doing what we want it to do, Pac-Man runs across the screen, bugs run up and down, they have horse races, all kinds of things. They drive high-speed cars on courses and so forth. The car doesn't move unless the brain's doing what we want it to do. Yeah, that's the secret. The second class of treatments are the brain drivers. These were developed largely by myself and my clinics at Harvard and here in Vancouver. What we do is we measure a particular aspect of brain functioning. Based on that measurement, we stimulate with light and sound. With adults, we also use electromagnetic fields, microamperage of stimulation, and so forth, to nudge the brain into more normal functional ranges. Now, the advantage of those procedures is that the child can be tasking, for example, reading or writing something or answering questions, while the area responsible for that activity is under treatment. Enormously effective treatment procedure, as you might imagine. Our learning expert, Mari, has been able to teach kids to read in 6 or 7 sessions because you're addressing the specific area associated with that activity. The third class of treatments are home-based, things that we give the parent to use at home that we know influences the brain in a particular way, things like harmonic sounds, for example. The good news, once it's fixed, it's fixed. And it's safe. There are no side effects associated with this, other than the IQ goes up, by the way. So the child may become insufferably intelligent. There was a recent article from Harvard Medical School pediatrician Dr. Katie Campbell, and the quote she has, "The therapy most promising by recent clinical trials appears to be EEG biofeedback."
Well, you've had patients, kids come in, and I've known one of them actually, and it was funny, after the initial brain mapping assessment, the very first visit you have with the child, he said to his parents, after you talked back to them and said, well, these are maybe things you're feeling or going through, he said on the way home, he read my mind. And in that, it was very interesting because he was very, very reluctant to go through the treatments, and he, there's a lot of skepticism I'm sure that you're dealing with, which is one of the reasons why you're here. But after that, he wanted to go to the clinic, and he wanted to continue with the treatments. My question is there something that kids, or adults for that matter, can do that will actually make the treatments less effective? Now, is there anything you could do that actually makes the treatments more effective, perhaps?
There are a lot of things associated with treatment efficacy. One of the most critical things is who's administering it. This is true of all therapies. Neurofeedback and neurotherapy is not a standalone discipline. There are other things that we have to do, behavior therapy, all kinds of things. The one thing that we know from the clinical literature is one of the most important features of any treatment is who's doing it. So the therapist variable is really critical. It matters a lot, so that not all physicians are the same. There's no equivalence of treatment in that sense. One physician can be better than another, and everybody understands that. Well, one neurotherapist can be better than another, and I think everybody understands that as well. The second thing is commitment of the client. That's why we pay so much attention to speaking to the child. When parents come in with their children, I talk to the child. I ask the child what they collect and what kind of problems they're having. And as this child said, I read his mind. But I was talking to him. And when we get that kind of level of commitment, it makes a huge difference in terms of the efficacy of treatment.
When we continue with It's All in Your Head, is your child training themselves to be attention deficit? They might be by doing something that you may think is really not all that serious, but they might be doing it every day, and they may be becoming ADD because of it. If that sounds possible, is that possible, and what are they doing, Dr. Swingle?
They're not outside climbing trees, playing baseball, and looking for toads in the woods. That's what they're doing. In other words, they're sitting in front of TV screens, either watching TV or playing video games. We have compelling evidence that it's toxic. There are a lot of reasons for that. Let's just take TV as an example. The images change every few seconds. Now, what kind of effect does that have on a child who has difficulty sustaining attention? It doesn't take Sigmund Freud to figure that out. What you're doing is you're training shorter and shorter periods of ability to sustain focused attention. The video games are addictive. The way they sustain attention is ever-increasing levels of stimulation. Now, every parent who has a child that plays an hour or so of video games a day knows that it's addictive, because when they try to get the child away from the video game, the child gets angry. They sneak the video games. They do all the things that you would expect of an addict. If the game is a search and destroy metaphor game, then you have compounded problems because there's compelling evidence that it increases aggressiveness, which of course would make sense. If you have a search and destroy metaphor game that the child is spending hours a day on, you're training an emotional reaction to dealing with a problem, and that's dealing with it in an emotionally aggressive fashion. So, my advice to parents, treat it as toxic. If it's a social event, it's a different issue. Friday night, the family is sitting down, watching their favorite program, watching a movie, there's social interaction. That's a different issue altogether. Now, if you use TV as a babysitter for a child that's under a year of age, there's an area of the brain that doesn't develop, and it's that serious. So we're not only dealing with a behavioral, social issue here, but we're dealing with a neurological issue as well. And I think mothers intuitively know this. That's why I said at the beginning of the program, mothers outrank everybody. If you feel that the TV is no good, you outrank everybody. The TV goes, period.
He's Dr. Paul Swingle from Swingle & Associates, swingleandassociates.com. Telephone number 604-608-0444. This is information that I think some people don't want to hear, by the way. I coach a soccer team under 13-year-old boys. And one thing that has changed in the video game, and you talked about social time together, is this Nintendo Wii. Mm-hmm. Because you actually do actions and you actually play with your friends and family, which makes it active. Mm-hmm. Still a video game, but at least you're doing it as a group. But I've seen those boys sometimes stay up till 2 in the morning. They come out of their darkened rooms, red in the face, to come downstairs to get junk food, and then go back up there. And it's like drugs.
Mm-hmm. Absolutely.
So video games, TV, bad. And there's a collective gulp I'm hearing all over British Columbia right now. You're listening to It's All in Your Head with Dr. Paul Swingle. We're talking about ADD and ADHD. When a parent and a child comes into your clinic, what do they normally talk about, and what do they normally ask you or say that symptoms are? Because one of the big things you talked about right off the top is misdiagnosis, and you're finding that it's not an attention deficit issue, but there are other more insidious underlying issues that are happening to the child.
That, again, is one of the merits of neurotherapy, because we do a neurological assessment, and if we don't see anything there, and the parent is reporting attention learning problems, it may well be that the child has had a head injury, for example, or what is very common is trauma. The one area that is really problematic is bullying. Now, if the child is frightened and traumatized, they're obviously going to have learning problems. They're going to be afraid to go to school. The mother may recognize some somatic complaints the child has. Oh, I have a headache. Oh, I have a stomach ache. And the stomach ache improves markedly on the weekends, that kind of thing. Something's going on. And if we find that there's no evidence of any neurological reason for the ADD, then we investigate some of these other areas. Now, if the trauma is severe enough, we pick it up on the electroencephalograph. There is a trauma signature. If we see that, then the flags go up.
It could be that specific that when you look at a brain assessment, you could tell right away what it is. And when other people think it's ADD and they just have to go to the pharmacist or the doctor and get the drugs to sedate, they may actually be masking a deeper problem.
Absolutely.
Is there a relationship between ADD and addiction?
Yes, there's quite a substantial relationship between the risk of it and ADD, ADHD. First of all, stimulants like Ritalin are controlled substances. They can be abused. There's a lot of conditions under which Ritalin is being sold in schoolyards, for example. It is a drug of abuse, or can be a drug of abuse. So that's one side of the equation. The other side of this is if Ritalin is effective in reducing hyperactivity in the child, then that makes sense in terms of ADD being a predisposition to self-medicating behavior, which is what addiction is. And what we find is that people who are diagnosed with ADD or ADHD, the time from substance abuse to substance addiction is shorter. the number of individuals who become substance abusers is higher. The duration of the problem is longer. So you have a lot of indicators indicating that there's a neurological issue associated with that. Now, on the other side of it, when you have a hyperactivity problem, the child is very likely to be isolated and stigmatized in school because of his behavior. Being marginalized and stereotyped can lead to criminal behavior. So you have a higher degree of criminality associated with children who have carried these diagnoses. And a higher level of criminality can lead to substance experimentation, substance abuse, and so forth. So you have a lot of things contributing to this. The type of ADD is important in terms of the predisposition to which kinds of addictions. Now, the alcohol link is very interesting. Children of alcoholics have a higher probability of showing the same deficiency that's associated with genetically predisposed alcoholism. Now, a lot of these kids are diagnosed with ADD or ADHD, where really what it is a predisposition to alcoholism or other addictions. In other words, a predisposition to self-medicating behavior. Now, if you sedate that problem with Ritalin or something of that nature, these are the kids that usually develop tics and sleep disturbances when they are medicated for the ADD with Ritalin. The reason for that is the problem they're having is an area of the brain that's deficient in terms of self-quieting, and if you add a stimulant to that, you make the problem worse. Now, you haven't done anything to deal with the predisposition to alcoholism. You haven't done anything to deal with the attention problem when they were a kid. So this kid's a time bomb waiting to go off in terms of drug addiction, alcohol addiction, and so forth, and serious problems in school. This is, again, one of the major advantages of doing a brain assessment because you identify that right off the bat. This is not a typical ADD issue. This is a predisposition to self-medicating behavior because the brain lacks the capability for self-quieting. You address that problem, you solve a lot of problems, not only ADD, but a future predisposition.
You had a very interesting comment about one type of medication that is supposedly better than a current type of medication, and there's a reason behind that.
Well, it's interesting. If you're told that you should be switching from Adderall to Vyvanse, you might be interested to know that the drug company Shear is losing their patent protection for Adderall in April of 2009. And Vyvanse is the substitute, which has patent protection for probably another 10 years or so. So if you're being switched from one to another, it's an interesting coincidence.
Wow. I'm only starting to get really anti-pharma in the last little while. I know you've been there for a long time, but...
Well, there's a place for medication, and we work with a lot of physicians. If a medication gets you from place A to place B until you can get the situation resolved, and a lot of physicians really work with us very closely with regard to that.
Let's go to the phone and talk to Colin. Hi, Colin.
Hey, how you doing?
Great.
Okay, doctor, I've got a 13-year-old son who, over the last number of years, I've been trying very hard to get a label put on, and thankfully I did because I know there was something there. But what it is he's just tipped over the scale of ASD, autism spectrum disorder, and one of the things the psychiatrist handling the case was telling me was if you can get him through high school, then life's going to be a lot easier. It's those high school years that are going to be the cause of concern because young kids at this age are far more forgiving. I'm wondering if you're seeing the same thing in drug addictions and ostracization and isolation with ASD patients, or do you even work with ASD patients?
Yes, we see a lot of ASD patients in my clinic. We're one of the few clinics in North America that will accept very severe autistic clients. There are a lot of symptoms of ASD that are very similar to the ones of ADD, and ASD is treatable with neurotherapy. You have to be very careful about medicating ASD because you can really exacerbate the problem when you medicate these things. I would suggest, Colin, that you have a look at a website, and it's called gettingadamback.com. gettingadamback.com. That website is associated with a book by the same name, Getting Adam Back, written by Arlene Martell, a very courageous mother. Arlene's son was diagnosed with epilepsy and autism, and she was told at one point to put her child in a crash helmet and institutionalize him. And being a mother and understanding that she outranks everybody, including the lunatic that said that, she decided no way. And the picture on the front of her book is Adam in a tuxedo graduating from high school. And she talks about all of the things that she had to deal with and the treatments that she used, including neurotherapy, including diet, and a number of other things. So my advice is be very cautious about how you approach this. Look at the behavior treatments associated with it, and I would certainly do neurotherapy for any autistic spectrum disorders.
Thank you for your phone call, Colin. Dr. Swingle is live for another 15 minutes or so. Just had a phone call from Colin. He was asking about his 13-year-old son who has autism spectrum disorder. He was asking about caffeine and told that perhaps maybe caffeine, coffee perhaps in the morning might help perk him up, but he's noticed lately there's been a resistance to that. What do you know about caffeine and ADD or autism spectrum disorder?
Well, caffeine is a stimulant, and the treatment of ADD is central nervous stimulants. So, yes, you would expect caffeine might improve the situation. However, it's very short-acting. You know, it's the half-life is very short on caffeine, so that you might get a temporary improvement. The downside of it, of course, is if he has any conditions that are associated with elevated stimulation or poor stress tolerance, then you're going to get pretty negative effects of caffeine, tic, sleep disturbance, things of that nature.
You're listening to It's All in Your Head. He's Dr. Paul Swingle from Swingle and Associates on Melville Street in downtown Vancouver. The clinic's telephone number is 604-608-0444. So is there a difference in gender with regards to ADD, ADHD? Is one gender more likely to be susceptible than another? And then we'll talk about adult ADD. What about boys and girls and ADHD?
This is some of the more interesting data from a lot of the research that's been done. In young children, the ratio runs roughly 4-to-1, males to females. That varies depending upon what kind of ADD they're talking about, but basically 4-to-1. When you get up into adults, it's about even. Now, it's interesting to speculate why that's so. If you look at how many kids are diagnosed with ADD, it's overwhelmingly male. And the reason for that is they're the ones that are causing grief in the classroom. They're the ones that are acting out, being more aggressive and so forth. There's also a form of ADD that goes markedly undiagnosed in females, and it's called the high frontal alpha, alpha being a brainwave form of ADD. When you have elevated alpha in the front part of the brain, you get excessive talkativeness, flightiness, inability to stay on focus. These are the kids that are bouncing around, being very social, chatting it up, and driving the teacher crazy. Why does that go undiagnosed in females?
Because we have a notion that perhaps that's just normal female behavior.
I see. Okay. And then these females arrive on my doorstep at 40 years of age, seriously depressed. Their careers are in shambles. They can't sustain a job. They can't sustain a relationship. And the problem is they had a form of ADD that very severely interferes with achievement. It affects planning, organizing, sequencing, and following through on things. So these folks just have a terrible time of it, and they were undiagnosed as kids. Therefore, their academic performance and their achievement levels are usually markedly affected. We see a lot of adults with ADD, and the treatment, again, is we correct the problem where it resides, in the head. Now, it's interesting with adults because you have a history here of having to cope with the ADD. They're very likely to have had serious problems with sustaining a job. They're very likely to have had serious problems with addiction, alcoholism. With males, the problem is that very often they incorporate the ADD symptom as part of their personality, as the way they cope with it. And they will sit down and present themselves as, I'm just an easygoing, laid-back, disorganized kind of guy. I look him in the eye and I say, you don't believe that for a moment. What you're telling me is how you're coping with the ADD by making that a positive property of the way you're defining yourself. So, in treating the male, we have to deal with that baggage in addition to dealing with the neurotherapy. We don't have that problem with a kid. Same is true with females. They have a history of having to cope with all of this stuff. So their core emotional belief about themselves is self-loathing. We have to correct that self-loathing. Now, the other thing that we find with adult ADD is you have a lot of comorbid behaviors, and they tend to be social, antisocial, histrionic kind of things, personality disorders, in other words. And the personality disorders involve the frontal cortex, which is a form of ADD that goes undiagnosed in female children. It all kind of fits together, and it makes sense in terms of looking at how this plays out. Now, if you medicate at an early age, that's not going to affect anything. You're not going to change those conditions. So the sooner that we correct it, the more rapidly the process.
You were talking about some of those personality issues. Can you give us an example of some of those things that you see in adult ADD for women or men?
Sure. Histrionics, narcissistic behavior, the personality disorders associated with individuals who are clinging. There's a high degree of dependence because they need somebody else to verify their self-worth because their core emotional belief about themselves is so negative. So all of those things are personality disorders, and they're associated, with imbalances in the frontal cortex and problems in the frontal cortex in terms of the functioning of those self-regulatory areas. And secondarily, the secondary effects of core emotional belief, which is very negative because they haven't been able to get anywhere. They haven't been able to sustain a job. They're not where they want to be. And their only conclusion is that they're losers.
So let's get back to the treatment, the part of the game that your clinic has done so very well for literally almost thousands of people now since you've been around in Vancouver. And the first and most important thing about the initial diagnosis is that you can pinpoint with razor sharpness the core of the problem, so there is no misdiagnosis, and that's one of the reasons why you're here talking about it.
Yes, exactly. That's really the tremendous benefit of neurotherapy, is that the diagnostic process allows us to identify the exact nature of the problem. This, by the way, is one of the reasons why people want to be very cautious about who they go to have their neurotherapy done. We have a real problem with hobbyists who get involved with doing what they call Brainwave Biofeedback. They buy the equipment, they get minimal training, and they do one-size-fits-all. And there are a fair number of them popping up around the Vancouver area. Dr. Corey Hammond, University of Utah Medical School, has published a number of papers on warning associated with people that don't carry licenses to practice some health discipline like medicine, psychology, chiropractic, whatever. It's not a standalone discipline. The neurotherapy is integrated into other kinds of treatment modalities, so you want to be very cautious about that. Now, having said that, when we do the brainwave assessment, we can tell precisely what the problem is and exactly where to go to treat it, and it may not be neurotherapy. It may be a behavioral problem. If a child's being bullied in school, one of these hobbyists can do neurotherapy till the cows come home. Nothing's going to happen. But if we identify that as a bullying problem, then there are other methods that we use to treat that child's attention learning problems that has nothing at all to do with neurotherapy. But we identified it with neurotherapy.
The telephone number at Dr. Swingle's clinic is 604-608-0444, 604-608-0444, and you could visit his website on the web at swingleandassociates.com and find out more about the conditions that are treatable aside from just ADD and ADHD and autism spectrum disorder and all those things. Adults, kids, doesn't matter. You have patients of all ages, including the elderly patients, where you do brain brightening and all those kind of things. And just to talk about the cost very quickly of neurotherapy, how much is it, and is it covered by regular medical, or do you have to have extended medical?
Okay. The best bargain on the planet, because once it's fixed, it's fixed. And the break-even point with things like Ritalin is about a year and a half. The intake assessment is $180, and the treatments vary between $105 and $150 per session. A common ADD problem may be 15 sessions, something of that nature, to put it to bed. It is not covered by the provincial medical plan, which is an outrage. It is covered by extended medical. Now, there are caps on extended medical, so whatever they pay for a registered clinical psychologist is what you'll get back. What isn't covered, and this is an advantage, is a tax-deductible medical expense. Do I have time for one little thing?
Absolutely.
Talking or walking in your sleep is linked to lower risk of attention problems.
Interesting.
So we'll leave the listeners with that.
All right. Well, that's good.